Thank you for the opportunity to present this case. So I'll just quickly go through the patient profile. This is a 75-year-old gentleman. He was operated, primary total hip replacement was done in 2004. Last 3 years, the patient was hardly able to walk, hardly dragging his right lower limb 4 to 5 steps. Some comorbidities, history of prostatomegaly, hypertension, nothing major, non-diabetic. On local examination, the hip movements were extremely painful. Shortening was there, severe osteoporosis was there. This is one of the x-rays I could get him from 2012. And this is a recent x-ray. So preoperatively, this was Paprosky. The acetabular defect was significant. We could see the lysis as well and extensive erosion. That was Paprosky type 3, 3B. The Kohler's line was broken, ischial lysis. Some lysis has been started there. The teardrop is being destructed. We got a CT scan done, and the CT scan, yeah, just to get a better preoperative profile, CT scan was done. And it showed that there was only a thin layer, no floor, no acetabular wall was present as such. How do we proceed with this case? Like, what are my major concern here was whether to retain, the stem wasn't loose, there was no lysis in the stem if you see the pre-op x-ray. So do we go for only the cup revision? If we see the literature, definitely cement fixations are gold standard since like many years. But now uncemented, cementless fixations of the femoral stem are being warranted. Multiple literature suggesting the same, but then the dilemma still remains. And as a plan of management, so what we did was in supine position, we took the bone graft from the opposite iliac crest, removed the implant using the extended trochanteric osteotomy, removing the cement mantle.
Gaurav, what you did in
Yeah.
this is.
So I'll just quickly show that this was loose, the acetabular cup, this was the primary cup was loose. This is the immediate post-op X-ray. So we were concerned about the acetabulum. So bone graft was put. Even after the bone graft, there was significant defect. So we put the augment that is seen in the superior part and cementless fixation. So multiple difficulties in this case we had on table that there was a shaft femur fracture while putting the final implant. So at the distal tip of the ETO, there was a shaft femur fracture. So it was very difficult to handle, to reduce it on table. And this happened at 15 millimeter stem. So basically we had to put go one stem down, one size down.
Gaurav,
Yes.
did you take the lateral view preoperatively of the femur? And which stem did you use in this case? Is this a Wagner one or
It is a Wagner
another
stem.
Indian?
It is a Wagner stem, sir.
Okay. So
Yes.
did you take the preoperative lateral view of
So
the
it
femur?
wasn't possible. It was extremely painful. Hardly we could get a supine position AP view, and hence we got a CT scan done at
So
least.
might be bowing might be the reason that the fracture could have happened there.
Probably, sir.
Yes.
And osteoporosis was definitely quite significant on table because we had to struggle a lot with this.
Just quickly, one
Yes.
question.
Yeah.
So what? Oh, some more is there?
Sorry.
Continue.
Oh, sorry. So post-op day 4 patient was absolutely non-weight bearing since day 1, and patient suddenly complains of something getting rotated. While I was just adjusting the pillow beneath the knee, something rotated was being complained, and this is the immediate X-ray that we took. It didn't look like dislocation. I took him under CM. I checked for the movements. The movements were fine basically. So what we noted was the stem had synced in. If we compare this X-ray, the stem sorry, I don't know where is this going. Yeah. So if we compare the previous X-ray, the stem had sinked in. So basically, what we felt is the reason being we had to go undersize. At 15 mm, the shaft got opened up. There was a femur fracture, so that wasn't possible. Reduction wasn't possible at 15 mm. So we had to put a 14 millimeter stem, one stem undersized. And although the acetabulum was, the more we were worried previously was acetabulum, but that seemed to be absolutely fine. After final reduction, the everything was quite okay. Definitely not as stable as a primary, but we were quite careful, quite skeptical about this case. What to do now? What to do with this?
Sir,
Should
Natisan
I-
sir.
No, you have the cause there and you know the reason for the dislocation. So that has to be addressed. So you have to revise the stem.
Right, sir. So we did the same thing. We revised the stem, and in under the CM, we didn't find any, like we see a GT fracture over here, but it wasn't there in the CM. We were the stable. The construct was quite stable. So post-operative, this is the immediate post-op. So yeah, this is the immediate post-op. We have to upsize. The soft tissue status didn't support us much, but the post-op plan that we kept was non-weight bearing, let it consolidate, let it heal, medical management definitely going on. Uh, Quite good physiotherapy was going on, and this is the follow-up at 1 month. The patient was able to sit on his own, do his routine exercises. This is a clinical follow-up at 2 months. Patient started walking. So patient is at pain-free at this time. We were concerned about the multiple fractures. So we thought that patient is not complaining. So should we really be concerned about the two fractures that we see? One is at the greater trochanter and one is the previous shaft femur. At 2.5 months follow-up, patient is able to sit and stand on
Gaurav,
his
final
own.
follow-up. Gaurav, final follow-up.
Yeah. This is the most recent 3 months follow-up.
Radiological follow-up.
Sir, I'm still didn't get the X-ray. It is due this week.
Just
Yes, sir.
quick question now. So you said that you harvested the bone graft even before opening the right side. So
Right.
that is not acceptable. He is planning a revision surgery.
Yes.
So even before opening on the right side, implant is there inside. So you are taking a bone graft from the iliac crest opposite side. It's a risky. If there is anything inside, then that bone graft goes waste.
Waste.
So that should not be done. Definitely, I will not accept.
Right, sir. We were skeptical about how much bone, like how much iliac crest would be, because we were not sure how much screws purchase would we get. So opening on the same side was a little doubtful thing.
Hari sir, what could have been done better in this case?
I have two questions on this. The first is no question that that cup is loose.